On stage the speakers, um, Professor Chintan and Dr. Sonam Yangzis and Dr. Anchal Thakur. Dr. Samar Basak is going to join us in a few minutes, and we will be starting with the proceedings. Well, for this course, we have a very eminent faculty, very experienced, and the aim of this course is that we have so much of instrumentation coming in, new gadgets coming in, and also how to optimize the use of existing technology that is there with us. And for this, my name is Professor Amit Gupta. I'm from the Advanced Eye Center, PGI Chandigarh. And along with me are my colleagues, Professor Chintan Malhotra. She's also in the Cornea Cataract Refractive Surgery at PGI Chandigarh. Dr. Anchal Thakur, she is also with us as a consultant at the Advanced Eye Center, and Dr. Sonam. So, and of course, Dr. Samar Basak is there from the Drishti Eye Hospital, Kolkata. And so the course overview is that there'll be a talk on ray tracing aberrometry by Dr. Anchal. It will be followed by a talk on pentacam expanding indications by me. Dr. Chintan will talk about swift source OCT applications for the anterior segment surgeon. Dr. Sonam will be talking about corneal biomechanics, the when and why, and Dr. Samar Basak will talk about TFM diagnostics, which is LipiView and LipiFlow. We do have a keynote address, which is by Dr. Yung Feng from China, and that will be at the end of this instruction course. So I would like to first invite Dr. Anchal, who will be talking on eye trace and its application for corneal and lenticular surgeries. Dr. Anchal, please.
Can I have my slides, please? Yeah, thank you. At the outset, I would like to thank AIOS for giving me this platform to present this ray tracing aberrometry for corneal and lens-based refractive surgeries. So what is eye trace? Is it a missing piece in ophthalmological practice? Is it indispensable tool for a cataract or a refractive surgeon? And some real-world application with some case scenarios. This is how the eye trace looks like. It is actually a 5-in-1 system which provides auto-refraction, corneal topography, ray tracing aberrometry, pupillometry, as well as autokeratometry. So the principle behind is that it sends a laser beam of 655 nanometer through the pupil and measures the exact location where it reaches the retina by using retro-reflected light captured by some reference linear sensors. So 64 such beams are projected sequentially 4 times at different locations on the retina, a total of 256 points, and the retinal positions of all these rays are mapped, forming a retinal spot diagram, and a wavefront is constructed by emergent rays from them. Thus, deviation of those emergent wavefront from that what is entering the eye gives results to ocular aberrations. So let's come to some case-based scenarios, that is the applications of eye trace in lens-based surgery. I'll be discussing subsequently with some cases. Does the patient needs cataract surgery? Preoperative planning of cataract surgery, especially the EDOF and the multifocal IOLs, assessing the visual outcomes in terms of contrast sensitivity, and can we see the optimization or optimizing the results of cataract surgery using the depth of focus curve. This is a major wavefront map display in which total ocular aberrations are depicted in microns. The green are for the lesser or no aberrometric error, and the warmer colors depict advanced aberrometric errors. This is actually an objective documentation of the visual symptoms reported by the patient. So the eye trace beautifully gives us the objective quality of vision as is seen by this map. Another interesting map which eye trace tells us is about the actual ocular aberrations. It is the only instrument which actually dissociates the corneal from the internal aberrations. So it also gives us quantitative measurement of the ocular aberration up to 6th order of aberrations, and we can see this through this map. Coming to scenario 1, does the patient needs cataract surgery? A 42-year-old patient presented with diminution of vision. On refraction, the vision was 6/6. But he said, hey doc, my quality of vision is really deteriorating. So when we did the eye trace, we can easily see that the internal aberrations are contributing to the decrease in vision. So this is an entity called the dysfunctional lens index, which is actually based on the lens opacities, maybe they are cortical or nuclear changes, and it also depends on the aberration profile of the lens. So coming to choosing an IOL based on eye trace, is the patient a good candidate for a multifocal lens? So this was a 52-year-old male, accountant by profession. He wanted complete spectacle independence. Of course, as we can see on the eye trace, the internal aberrations are more, the dysfunctional lens index is gone down. So less than 5 is an indication of cataract surgery. It is actually not performing that well. And the same is seen as a decrease in contrast sensitivity. So the eye trace is dissociating the corneal contrast sensitivity from the lenticular contrast sensitivity or the internal aberrations. So the MTF because of the lens has decreased. And the same is depicted by the internal higher order aberrations, internal aberrations. So the corneal aberrations are very less, and because of the cataract, the internal aberrations have increased, which is contributing to the total eye quality of vision. The same thing can objectively be defined by a Strehel ratio. So what is Strehel ratio? It is the ratio of the peak height of the point spread function being measured to the peak height of a perfect optical system. So in this map here we get the Strehel ratio. The closer it is to 1, it is actually a perfect optical system. So coming to the very important map which the eye trace shows us is the IOL selection analysis. Whenever we have to plan for a multifocal IOL, we have to keep 2 things in mind. First is about the angle alpha, and second is about the total corneal higher order aberration. So this is the comprehensive map which the eye trace tells us, that is the IOL selection analysis. And the right side of this map, there's a checklist. So it gives us that are the corneal higher order aberrations present, are internal higher order aberrations present, and at the end, it tells us which lens should be considered. Along with this, it also tells us the corneal spherical aberration. So different IOLs, as we know, have different spherical aberration. And if the cornea has a positive spherical aberration, we should plan a IOL with a negative spherical aberration so that we have a residual positive spherical aberration with a good depth of focus. Thus, for this patient, we can see here that the corneal spherical aberration is plus 0.29. So we can plan a lens, no financial disclosures, but we can still plan a lens with the Alcon lens, which has a negative spherical aberration, leaving a residual positive spherical aberration to have a depth of focus. Thus, the eye trace is giving us an idea that we can plan a multifocal lens for this patient. Also, a total astigmatism, which is seen here, is less than 1. So, it is also suggesting us a monofocal, non-toric IOL. Coming to post-operative quality of vision, we can see beautifully in this map that after the surgery, cataract surgery, the internal aberrations have gone, the DLI has improved to 10. Similarly, with the internal aberrations, you can see that quantitatively the aberrations have gone down, and the MTF has drastically improved. Now, I would like to just spend some time on this slide. This is actually a depth of focus curve. If we omit this pink line and we only focus on this blue curve, you can see that the height of this mountain depicts the best vision. That is, if the patient has a minus 0.45 correction, he'll have the best vision. 50% uphill of this mountain is the usable vision. So, for the right eye, after cataract surgery, this thing, which is written in blue, depth of focus, is for the right eye, 1.43. if we want to give the patient the best outcome, that is a continuous range of vision, we need to place the other depth of focus curve exactly when it is bisecting 50% of the blue line. Like in this picture, as you can see here in this map, this pink line is cutting this blue curve exactly approximately around 50%. So these two curves have to be placed correctly for a continuous range of vision, and there should be no gap in between so that the patient has an excellent outcome. So especially patients which we are planning for EDOF lenses or multifocal lenses, this depth of focus curve is very useful in giving optimal outcomes to the patient. Coming to scenario 3, a 24-year-old female patient presented with diminution of vision right eye since 4 years. As we can see in the anterior segment picture, there's slight bulge in the posterior capsule, which we can very nicely see in the retroillumination picture. This is a oil droplet reflex. And the anterior segment OCT, we can see a nice bulge in the posterior capsule, suggesting of posterior lentigonus. So what does the eye trace tell us? The eye trace tells us that the dysfunctional lens index has gone down. So any abnormal shape of the lens will also cause a decrease in the dysfunctional lens index. The patient might not have a cataract, but still have a very low DLI, suggesting that cataract surgery would definitely improve the visual outcomes. Similarly, the MTF, because of the internal thing, has gone down, and the DLI is of course less. The magnitude of higher order the aberrations because of the internal thing are very high, as we can see in this map. So post-operatively, we placed an IOL in the bag, and it was actually centered. Post-operative, what we can see here, the eye trace is showing us that the visual quality has improved, suggesting that patient did need a cataract surgery. Sometimes it is very important tool to make the patient understand that will the patient improve after cataract surgery, or the patient will have a high amount of residual amblyopia. Post-operatively, we can see after the surgery, the MTF has improved, and the higher order aberrations because of the internal aberrations, they have completely gone. So this new era of patient expectation, like 2020 patient, unhappy patient, is unacceptable in the 21st century, because cataract surgery is now a refractive surgery, and the future is quality of vision, and this quality of vision can be achieved by using this gadget called the eye trace. Thank you.
Well, thank you, Dr. Anchal, and I think Dr. Anchal has very expertly addressed all the points. Important to understand is that this is a gadget which helps the ophthalmologist to understand what the patient is complaining about, and also it helps us to explain to the patient what's wrong with his eye. And especially this concerns the cataract surgery. I had a patient of mine who came, he'd got a CT scan done, he had diplopia, I went to a squint specialist, everywhere, nothing. So then we did an eye trace, and it showed that diplopia, it showed a DLI value which was significant, and we went ahead, operated, and it went away. So I think it's an excellent gadget. Any questions from the panel for Dr. Anchal, please?
Dr. Anchal, could you explain a little bit again once how the depth of focus, how you would use that to, once you've done cataract surgery for one eye, then how do you do it for the other eye now?
Yeah, actually the depth of focus is another way to plan monovision or a mini monovision. So once we plan a cataract surgery, we operate the dominant eye first, and we try to achieve maybe plano or maybe a slight minus. And after the cataract surgery, we should look at the depth of focus curve using the eye trace, and then plan the other eye cataract surgery, how much residual myopia we need to leave for the other eye, so that we have a continuous range of vision when the patient is using both the eyes. Especially with the EDOF lenses and the multifocal lenses coming up, this depth of focus curve can actually extend the range of vision.
Dr. Anchal, congratulations. It was a wonderful talk. My question is a follow-up question to Jintan ma'am's question. Do you rely on the subjective defocus values, at the same time the patient's refraction, primary refraction of one eye which is operated, and then refer to the eye trace, or it's like which one is more reliable, which parameter is more reliable to stick on?
This is a very good question. The subjective depth of focus is actually more than the objective depth of focus which the eye trace gives us. So even if we plan according to the eye trace, we'll end up landing a more continuous range of vision, because the subjective depth of focus will be much larger than what the eye trace is showing us. But definitely we can plan it, because objectification can be done using the eye trace.
Thank you so much. With that, we will move on to our next talk, which will be elevation-based tomography with the pentacam, expanding indications. This will be given by Professor Amit Gupta from the Advanced Eye Center, PGI Chandigarh.
Well, thank you. And as we know that the Pentacam works on the principle of Scheimpflug, photography, and it's a tomographer, and leads to a 3D reconstruction of the anterior chamber. And there's quite a big drop down which comes once we have to see what data of the patient we want to analyze. So if we go first to the overview map of the patient, in one glance, it gives us a lot of information of the curvature of the cornea, of anterior chamber analyzer, keratometric values. It gives us a 3D model of the anterior chamber and also the Scheimpflug imaging of the eye. And one rarely used map is a MAPS chamber, which is basically, it concerns the anterior chamber depth, helps us to plan ICL surgeries, identify patients at risk of glaucoma, follow them up after surgery, and so many other applications. If we come to Scheimpflug images, at one glance, it shows us the anterior posterior curvature and the relations. For example, in this photograph on the left, we can see it's a patient of keratoconus. It's thin in the center, and we look at the periphery, the ratio is totally disturbed. Also, this Scheimpflug images, this is a patient of femtokeratoplasty, and we can see the mushroom-shaped border of the graft on Scheimpflug imaging. Also, it can be used to measure the ICL vault in these patients. It does have a nuclear staging and a 3D cataract analysis, which can be done using the Scheimpflug imaging. Also, something which is not used that often as it should be is fast screening report. And this is what it looks like. The two bell curves, one is red and one is green. And it shows various values. Basically, the red bell curve is that of the pathologic population, and the green one is of the healthy population. The black line indicates where the patient's data compares. So just at a quick glance, we can see the anterior chamber profile, we can see the corneal thickness profile, we can see the corneal surface, the corneal clarity, as well as the cataract grading in this patient. And of course, as I said, the nuclear staging module, it helps us to customize phacoparameters before the start of surgery. If we come to further colored maps, which are there in the first section of the drop down, it gives us the basic topography info of the patient. So this is a typical 4 maps refractive, and it gives a sagittal curvature of the front. It gives us a map of the corneal thickness. It gives us some front and back elevation maps of the cornea. So this is usually the first map which we start off with. And just to go over some values which are significant, if the elevation on the anterior surface is more than 15 microns, we regard it as a significant at risk for ectasia. And if the elevation of the back surface is more than 20 microns, it is also regarded as significant. And preferably the difference between the two should be less than 5 microns. And this is something known as the Belen-Ambrosia enhanced ectasia display. And if we look at this display, it also gives us a value called the D value, which is a composite of the deviation of various parameters of elevation, which is away from the normal. So from this comes the concept of the best fit sphere, against which the values are given. So a sphere, usually it is 8 millimeters of the cornea, and it assumes the cornea to be equally curved in all directions, which is not accurate in astigmatic or irregular eyes. And it may be useful for detecting gross abnormalities, but the best fit toric ellipsoid is, it takes into account both the asphericity and the toricity of the patient. So it is highly accurate in early cases of keratoconus or very subtle changes we want to see in post-surgical corneas. So this is the standard reference, and it is particularly relevant when we want to study the posterior elevation in detail. So why it matters is that the choice of the reference shape directly influences the elevation values, and the protrusion may appear subtle on the best fit sphere, but clearly on the best fit toric ellipsoid. So, and this is especially useful for early keratoconus. So in one case, a 27-year-old female wanted refractive surgery, stable refraction, and manifest refraction of minus 4.25. And we can see, look at this map, and shows a slightly steeper cornea, a reasonable corneal pachymetry, and same for the other eye. And if we look at the Belen-Ambrosio display, it shows the values in red as an abnormal values, and also a borderline D value, similarly for the other eye. Now, in this case, would you do refractive surgery on this candidate or not? So what I wanted to bring out was that if we look at the white to white of this patient is 10.5. So this is, on this map is, we should not just read it with our eyes closed and say this is red and not do it. So a small white to white or even a large white to white more than 12.5 can alter not only the bad D maps, it can alter the pachymetric maps, it can alter the artmax values, and this can lead to false positives or borderline scores which are confusing and are sometimes crucial for both the refractive and keratoconus diagnosis. Thickness progression map is a good map. It just tells us the standard deviations within which the pachymetric thinning progression or thickening profile of the cornea is normal or abnormal. Another clinical situation, a patient or high myope, -5 with -1.5 cylinder and -6 with -2.5 cylinder. And if we look at these maps of these patients, we can see that the cornea is on the thinner side, and patient wanted a refractive surgery. This is the other eye. Again, shows a reasonable profile with a thin pachymetry. And if we see this, so this is a thin cornea with a suspicious D value, and we calculated the residual stromal bed thickness was also less along with the PTA. And so what next for this patient is, since the patient had a reasonable anterior chamber depth, we planned this patient for an ICL. In ectatic corneal disorders, important to understand definitions, form first keratoconus and keratoconus suspect and subclinical. Form first when the fellow eye of a clinical manifest keratoconus eye. There is no clinical finding except for certain topographical changes, and a suspect when a localized area of abnormal inferior but maybe central or really superior area is present. And in a subclinical keratoconus, a fellow eye of a clinical manifest keratoconus with following features, that is no clinical finding and some amount of asymmetry. So this 28-year-old male, refractive error, which is minor with a little bit of a cylinder thrown in, and we can see the values of the patient. It appears a little reasonably okay except for the elevation on the back surface, and we see the Belen-Ambrosio map of this other eye of the patient. And similarly, if we see the left eye of the patient, we see the findings which are just borderline values and a little bit of anterior elevation and a D value of 2.46. So this is a 28-year-old female with a anterior and posterior elevation and a bad map abnormality. And so this is a keratoconus suspect, and we should observe these patients at reasonable intervals with pentacam and follow them up. Also, another patient, 24-year-old male, right eye not accepting and left eye with a bit of a cylinder, 0.75 cylinder. So overt keratoconus in one eye, and if we look at the other eye of the patient, there is an inferior steepening of the patient in the patient's eye. And so right advanced, left form first keratoconus, plan was right DALC and left eye 6-monthly observation in this patient. So we do have these maps which show us at a glance whether the patient is progressing or not. And in every patient of keratoconus or keratoconus suspect, we should take a look at this map. There are green flags and red flags, and so basically in established disease, if the follow-up reading crosses the red flag, it's significant, any one, or if there are two parameters which cross the 80% dotted line. And similarly, in very early disease, even if it crosses the green gate, it is considered to be significant in these patients. So this is a patient's map, and it shows, or the pink line shows that the patient has progressed from the last visit, and this should be considered as a progression in these patients, and probably patient should be taken up for cross-linking instead of just observing. Another use of the topometric map is to plan the intact surgery and decide on which axis you want to the incision and how to place the intacts in these patients. And this is a pachymetric map, and we use it so often, you know, to plan DALC or to plan intacs or femtokeratoplasty and so many other procedures. Even the depth of the flap in SMILE and LASIK can be planned by using the pachymetric map. Going to the further down on the drop down, it's very useful is the comparative display. So for example, a patient who's post cross linking, and we want to see has the patient done well after cross linking. So it subtracts the data from the two readings and gives us the, so in this case there is hardly any change on the bottom right corner, so it indicates that pentacam is stable in this patient. Now, in some cataract surgery situations, this is a patient of keratoconus. Now, some publications have shown that the use of total corneal refractive power when we are doing biometry is critical to having a good outcome and avoiding hyperopia in these patients. So, if you go to the cataract pre-op map, the middle map shows us the total corneal refractive power. And it has been by Watson et al. They've said they use the TCRP at the apex. So in this case, it is like 52.8 at 3 millimeters, and this patient did quite well after surgery. So again, a patient who's operated radial keratotomy. So these are distorted corneas, and they have a lot of flattening in the center, and also in irregular corneas we can see in the 4-map refractive. And so in these cases also we can use the pentacam holiday report, and so it shows us the aberrations of the cornea. It can tell us the chord mu to show the centration, that is whether a good candidate or a bad candidate for a premium IOL. Also the monofocal eye. So in this case we planned a monofocal IOL with the negative spherical aberrations, and so this is one of the ways that, you know, we can use the pentacam in complicated cataract surgery. Of course, one very important map is the EKR detailed report. So what it does is it shows the distribution of K readings in these patients, like a patient of post-refractive surgery or post-radial keratotomy, by bringing in a corrective factor compared to the normal. And this is then, if there are zones which are like 2, 3 or 4.5 millimeter zones. So this is a weighted mean which is then given by the pentacam. So weighted means that values of some parts, like the central part of the cornea, are given more weightage than values in the periphery. So this gives, it's not a mean or an average, so that gives a better value on which to plan the surgery. In this case, the patient was -1 post-operatively. We used the EKR at 3 millimeters in this patient. So summing up, the pentacam is a very useful tool for not only screening for refractive surgery and planning laser vision correction or phakic IOLs, also to diagnose keratoconus and follow up and manage, for example, cross-linking. So important to see whether it's worked or not and how the patients are doing. And also, do you plan intacs or DALC or femtokeratoplasty or even a keratoplasty you have to decide the diameter of the patient in the graft in a keratoconic eye. So you can use that. And I even use it to follow some patient of herpetic keratitis. For example, we want to see the edema, and we have the pachymetric map, and we can follow up whether how well the patient is doing, or a fuchs endothelial corneal dystrophy. The pachymetric map is a great map to see. Also, it can help us to see post-PK patients, help in selective suture removal, help in toric IOL planning, lens density, and the IOL power calculation, of course, after cataract surgery, contact lens fitting. So the list is endless. I think it's an important tool. This is the team, cataract refractive in AEC-PGI, who I would like to thank, and all of them contribute so much to whatever we say or do here. Thank you so much.
Thank you, Professor Amit. I think that was a very, very comprehensive coverage of the uses of the pentacam. Any comments from the panel or any questions from the audience?
Yeah, it was a great talk, sir. I would just like to ask, at which map would you like to look at when you plan a toric IOLs particularly?
The aim of us when it comes to using a toric IOL is, one, to see whether the surface is regular or it has an irregular astigmatism, which is fairly clear when it comes to just if you see a 4-map refractive, it is all right. we can go to the TCRP maps or to TrueNet Power maps. I don't use that usually. I rely on the IOL master. I do take a look at the pentacam, see that the but I don't use those readings of pentacam to plan my toric IOL surgery. I don't do that. Yes.
So, thank you, sir. So now I would like to request Professor Chintan ma'am to present her talk on swept source AIOS2025 applications for the anterior segment surgeon.
Thank you, Sonam, and thank you to AIOS APO as well as Dr. Amit for including me in this course. What I'll be speaking about over the next 10-12 minutes is about the swept source OCT and how it can help us in the anterior segment surgeons. If we go to the AIOS-OCT systems, there are different technologies available. We have the time domain, the spectral domain, and the swept source OCTs. Each of these have different properties. What the swept source basically has the advantage over the other two is that it has a much greater scan depth and a scan width as compared to the time domain and the spectral domain. The axial resolution of the swept source is good, although it's a little less than the spectral domain. And it has a very high scan speed, so which makes it easy to capture images even in patients who are somewhat uncooperative, like small children. So these are two images which are showing the picture on the right side of the screen, showing the CASIA 2 OCT, no financial interest, which is a form of swept source OCT, where the depth of the scan is 7 millimeters and the width is 16 millimeters. So there's limbus to limbus coverage. On the other side, we have the spectralis OCT with the anterior segment module, where the scan depth is only 2 millimeters and the width is 6 millimeters. So with the spectral domain, if we want to see, for example, in this picture shown an ICL, we cannot see the cornea. Whereas with the swept source, we can see from the apex of the cornea to the lens. So with the swept source ACT, the cornea and the lens, including the posterior capsule, can be visualized simultaneously. Now, there are multiple purposes for which the swept source OCT can be used. And in fact, I would have to say that, like for even in our department, beyond the cornea surgeons, is the glaucoma surgeons as well as the strabismus surgeons who are using the OCT as much as we are. But I limit myself to the corneal and lenticular applications. So the swept source OCT has brought about a significant change in the management of lenticular disorders because of our ability to see the lens. And I'll just run you through some of these scenarios. For example, in white cataracts, once we have an OCT, we can modify our surgical technique depending on the presence or absence of fluid and the status of the posterior capsule. For example, this cataract, we see that there is no fluid and the posterior capsule is intact. It's a compact nucleus. So we can comfortably go ahead with the single stage forceps or needle cystotome capsulorhexis and not have to worry about the running away of the capsulorhexis. On the other hand, in an intumescent cataract with fluid pockets which are present both anteriorly and posteriorly, it just makes sense to do a needle aspiration prior to initiating the capsulorhexis, which will decrease the risk of an Argentinian flag sign. In traumatic cataracts also, when the lens matter is very flocculent, we can try and see the contour of the posterior capsule. It may not always be visualized. For example, here we can just see a part of the posterior capsule, but the contour can give us some idea whether the PC is intact or not. This is beautifully captured in this image where this patient developed a cataract after receiving intravitreal steroids 1 month later, and we can see the breach in the posterior capsule so beautifully. And this helps us again in planning preoperatively. We know that we are going to need a vitrectomy probably and the type of lens that we want to plan. In traumatic cataracts, the sensitivity of the swept source OCT has been shown to be extremely good. It's close to 97%. And the advantages of a swept source OCT over the UBM are that it's non-contact, so it's safer in cases with repaired scleral wounds. We have better cooperation in children. The only drawback being that structures behind the iris cannot be visualized, which can be seen with a UBM. Then AIOS-OCT is also being used a lot in posterior polar cataracts. For example, in this picture D, which is being seen, we can see that the posterior polar cataract is there, and it's difficult to identify the posterior capsule posterior to the plaque. So this is a grade 3 posterior polar cataract, and here we have it's been shown to have around a 60% risk of a posterior capsular rupture. This is one of our patients. We see that there is a dense plaque of posterior polar cataract, but this falls in grade 2. That is, there is no clearance between the opacity and the posterior capsule, less than 50%, but the posterior capsule is visualized. So the risk of a PCR in this case would be a little less than a grade 3. And post-operatively, we were able to implant the IOL without PC rent, but we can see how flaccid the capsule is. Phakic IOLs, the Swepsos OCT can be used for ICL sizing software. For example, we have the NK formula and the KS formula, and these can be used, especially in borderline cases where our manual digital caliper where we are measuring, we can correlate with these. Post-operative evaluation of the vault height and the crystalline lens rise. So if the crystalline lens rise is more positive, then we want to go in for an ICL with a higher vault vis-a-vis if the crystalline lens rise is negative. And this is just showing how we can measure the AIOS2025 vault height. And then the sizing for the ICL vault height and for the sizing for the other eye can then be tailored according to that. This is another interesting scenario. So if we have a white reflex in a patient having undergone cataract surgery, it could be multiple things. It could be a PCO, an after cataract, or it could be something else. And this is where, of course, clinical examination is must, but this is where it helps us. So this is a case of an IOL opacification, where there were deposits on the surface, and the internal part of the IOL is clear. So this needs an explantation and an IOL exchange, and not a YAG cap, which somebody otherwise might mistakenly try to do. Another case, if you see a white reflex, this could be capsular back distension behind with fluid collected behind the IOL, and this would probably respond well to a YAG cap of the anterior capsular margin. I will not dwell on this, but this is one of the most important uses of Swepsos OCT. For example, we have the IOL Master 700, these are the Swepsos OCT based biometers. Apart from giving us the IOL, because they are targeting right from the corneal apex to the macula, we can check the fixation and the lens tilt, and also it measures the posterior cornea. But biometry is a separate subject, and I'll leave that for now. Coming on to the second part of my talk, I'll talk about AIOS2025 in corneal practice. So AIOS2025 and Swepsos is a part of the AIOS2025 family. So in some situations, it would show more benefits, but otherwise it would be the same as other OCTs. And we can use it for medical management as well as surgical management. I'll just run through a few case scenarios. So for example, this is classic, we know. This is a lesion seen on the cornea. There is a hyperreflective thickened epithelium with abrupt transition on the cornea. So we know that this is almost diagnostic of an OSSN. That being said, it's also useful to monitor the resolution of the disease. For example, in this patient, we gave mitomycin C for 3 cycles. Clinically, it seemed to have resolved almost completely, but we can see that the hyperreflective epithelium was persisting, and so we have residual disease after 3 cycles of mitomycin C. And we proceeded to give an additional 2 months of interferon so that the resolution was complete. These are 2 cases, an 18-year-old male and a 55-year-old lady. We have 2 lesions on the OCT which appear very different from the ones that I showed for the ocular surface squamous neoplasia. Here, both the lesions are homogeneous, they are hyporeflective, and they are subepithelial. The epithelium, in fact, is thin. The borders are smooth for the lesions. And this is the picture which has been classically described for lymphoproliferative disorders of the conjunctiva. Now, lymphoproliferative disorders follow a spectrum from very benign to low-grade malignant and then highly malignant. And so this is what it showed in these patients. The biopsy, the 18-year-old male had a history of vernal keratoconjunctivitis. So this was a benign reactive lymphoid hyperplasia. Whereas the 55-year-old lady, she had a follicular low-grade lymphoma. And this is the picture of that lady. So this lesion, on clinical examination, we could have thought it to be a melanoma, amelanotic melanoma, or a lymphoma. But the OCT is quite suggestive of a lymphoma, and we got a PET scan done for her, and there were hot spots in the periaortic lymph nodes. The second use is the role of AIOS2025 for microbial keratitis. Now, various patterns have been described. You could have inflammatory plaques on the epithelium, the endothelium, fibrin in the AC, and stromal thinning and necrosis. The AIOS2025, unlike a confocal microscopy, the pattern is not specific to any particular microorganism for most of the lesions, but it does help us to determine the depth of involvement, to monitor the course of the disease, and to titrate treatment. For example, this was a 24-year-old girl with fungal keratitis. LASIK was done somewhere outside, and she developed a minor trauma and developed this. And so we could comfortably measure her course over time, seeing that although the lesion was fairly deep, but at no point there was evidence of any thinning or a risk of perforation, which could be seen clinically also, but an AIOS just helps to, monitor the resolution more easily. And in the end, she healed with a scar which was subepithelial, but the vision was maintained at 6/9, and so nothing further was done. In some cases, though, however, especially for retrocorneal plaques, it's been seen that the characteristics may indicate a broad etiology. For example, in fungal keratitis, the borders of the plaque have shown to be irregular, whereas in a hepatic keratouveitis, very clear demarcation has been shown. Now, these are not 100%, but these are suggestive. And so this was one of our cases, the two pictures on the left. He was a diabetic, a fulminant kind of a keratitis which was not responding to fortified antibiotics. The scrapings were not coming positive. The PCR was not showing any results. Not responding to fortified antibiotics. So as the patient was not responding and he had keratic precipitates at the back of the cornea, we just tried to have a closer look at the OCT. And this seemed to resemble the picture on top, clear borders, and which is why then we went ahead and gave antivirals, oral antivirals, and after a few days, oral steroids, and there was a remarkable improvement. This is a 70-year-old male referred with post-op non-resolving corneal edema 1 month after phacoemulsification. And this is where I would like to highlight the role of a swept source OCT. So there was only corneal edema, no DMD detected on a spectralis. But if you do a swept source OCT which has a greater depth of penetration, one could nicely see that there was a descemet membrane detachment which was there in the periphery, and the center was probably missing. And so a post-C3F8 injection, the patient cleared up. In the periphery, we could see with the spectralis also the DMD, but the resolution was much less, much better with the spectralis. AIOS can also be used in keratoplasties, for example, to monitor the graft thickness in this cases of corneal rejection. As the graft thickness goes down, we know that the rejection is improving, the corneal graft. This is a case with bilateral granular dystrophy. The depth of the OCT helps us to plan the surgery. This was 200 micron depth. We planned the ALTK with a 200 micron head, using the 250 micron head because that's what we have available. And once it was planned intraoperatively, one could see the thickness of the graft which was there. And we could see that this was approximately a 1/3 graft thickness which we got, the button. And then it helped us to monitor post-operatively also how the graft thickness gradually came down over a period of 10 days. The same for managing a recurrent case where we had a superficial recurrence, and this could be managed with a PTK. Similarly, for endothelial keratoplasties, I'll just take a few seconds more. I'll run through this video. We can monitor the attachment of the DSEC lenticule, and we can monitor how the graft is improving over time, the thickness improving and the clinical picture improving. So to conclude, the swept source OCT provides a greater depth of penetration and a larger field of view. Visualization of lenticular pathologies has dramatically changed, and if available, it should become a part of our routine workup for some special situations in cataract. Purely corneal pathologies, spectral domain OCT has an edge because of better resolution. Thank you for your patient hearing.
Thank you, Dr. Chintan. I think that was a wonderful display of the third eye for a cornea specialist. I would like to call anti-segment OCT, because it goes beyond sometimes what we can see. Any questions for Dr. Chintan on its use in cataracts? I mean, I think it's summed up so well. Especially, I would say patients who have undergone intravitreal injections. They are the very nasty cataracts, and they show such a surprise on the table. I think it's a must for each and every case. And you should do, and especially in case of ocular surface tumors, lymphomas. I mean, although Dr. Chintan touched about it, we have patients of like benign lymphoid hyperplasia, or it is a lymphoma, and how they need to be investigated, some hemogram or some detailed blood investigations. And that can actually, although it has doesn't have a very high level of correlation with systemic lymphomas, it is there, but and usually it is not a life-threatening thing. It does make so much of a difference to than just letting a red patch go. We do see these salmon patches, and ever since we started looking for them, we are diagnosing them more
Yes,
and more.
that's true.
I don't think we ever diagnosed lymphomas till we got the ASOCT actually,
Yeah.
and now we have several patients in our practice we have diagnosed as with the salmon patch lymphomas and benign lymphodyperplasia. Any questions from the panel? And Dr.
Just
Basak, is there any
one
comments or
comment I'd
questions?
like to make.
Yeah.
Yeah.
Excuse me.
Very nice.
Thank you, sir.
Those pictures actually, really this ASOCT actually makes our life easy. So what we follow that beautiful pictures, all images are so valuable for the corneal surgeons,
Sir, voice little closer.
for the corneal surgeons. Especially it is for endothelial keratoplasty. Sometimes that when you get the referral from the peripheral colleagues, the Shamurda do a DMEC or DSEC. So, but sometimes you cannot pick up in slit lamp because cornea is so
Yes.
thick and it matters. And there if you have a good OCT in your hand and you surprise that there is DMD.
Yeah.
So life is easy. So explain the patient. That is also for counseling of the patient. These are very, very important. That okay. So guard your colleagues that I will give a try. Probably you will not require a keratoplasty. So I'll give a try. Sometimes they come late, so it matters. One injection might fail, then you have to give. So serial OCT on different post-op days after injection is very much important. So in my practice actually what I do OCT prior to my surgery or all PPK cases. All PPK. This is for many reasons. One is to see any DMDs or DMD is, it is there, it is intact DMD or the surgeon has eaten away some of the area.
Yeah.
Desmet. Second thing, to measure the corneal thickness also. At the same time, it gives the corneal thickness. And I also take the other IOCT, normal eye, to explain the patient what is wrong in your this eye. Sometimes they cannot understand. So your thickness in this eye, say 500, is 700. So we'll make it happy. So it is for counseling, for our own understanding, and post-operative, of course, I see my patient on, DMEC patient on, not on day 1, rather on day 2 of surgery. Day 1 still some air or gas is there. Day 2 it is like 3/5 gone. So you could detect the detachment, early detachment on day 2 or day 3. So you see, and again explain to the patient that these are then we have formula like 1/3 detachment or more than
Yeah.
1/3. Then you give a, like you observe the patient or immediately you take the patient to OR and give again injection. So it makes our life easy. And as you rightly said that in microbial keratitis, we do in all cases of microbial keratitis, both ASOCT and angiosegment photography. This is also for counseling of the patient, not for our understanding. Counseling of the patient is very much, and we always do in both the eyes. What is normal they should know,
Yeah.
and then what is abnormal in that particular eye. And sometimes you see plaque, and that your change in diagnosis. Sometimes you see severe necrotic zone. Probably you are thinking it might perforate. So this sort of lot of things and help actually, even for that case that if you want to give intrastromal injection, your OCT also tells you that what is the surrounding healthy area. Because we try to avoid the necrotic area, then there may be disaster. So we give like that way.
Even for like keratoconus, I didn't touch upon the depth of scars, how much desmet is
Keratoconus
involved.
is
Yeah,
again
yeah,
another area.
yeah.
So that way, if you have full, like you showed, we have solix and other that gives full anterior segment up to the posterior capsule of the lens. So that, as you said, rightly
Yeah.
said, the PPC and all these things, lens fluidics, everything. So you can easily, and you can measure them. That is the best part, like halting of the ICL. You can actually measure them. Wonderful tool.
Well,
Thank
thank
you,
you,
sir.
sir, and thank you, Dr. Chintan. We'll move on with the next talk, that is Corneal Biomechanics, the when and why by Dr. Sonam, and she's from the Advanced Eye Center, PGI.
First slide. First slide, please. Slide number 1, please. Yeah. This is not. Okay. A very good morning, everyone. At the outset, I would like to thank Professor Amit Gupta, sir, for giving me this opportunity to present here. So, what is biomechanics? Basically, it is mechanics that is applied to any biological tissue or any biological material. So, the assessment of deformation and the equilibrium to the corneal tissue under application of a certain force. That is how we measure biomechanics. So, corneal biomechanics will govern its shape. So, we know the cornea is mostly a spherical structure. So, the inherent viscosity of the eye along with the intraocular pressure, the balance is maintained to maintain the shape of the cornea. So, and hence the refractive power of the eye. So, the corneal thickness is a static physical property. So, we cannot just rely only on the thickness of the cornea to measure its strength. So, the biomechanical behavior is mostly a dynamic property, and the collagen lamellae, the way it's stacked up in the stroma, is responsible for the elastic property of the eye, while the glycosaminoglycans are responsible for the viscous property. So, cornea is mostly is a viscoelastic substance. So, there are other factors that can affect the biomechanical strength of the eye in the form of hydration, diabetes, or axial length, IOP, which I will cover in subsequent slides. So, there are some factors which we need to understand. What is elasticity? It's the ability of the deformed material to return to its original shape when the force causing the deformation is removed. So, it's again measured by the Young modulus. Here in this line diagram, we can see that the stress and strain ratio here, loading and unloading, is same. It's a linear graph. While a viscosity, what is viscosity? It is the measure of resistance to the flow. Just like honey or any viscous material, the deformation velocity is little faster, but the relaxation rate is slower. So, in this graph which explains. So, coming to the eye, the cornea is a viscoelastic substance. So, it exhibits both elastic and viscous behavior at the same time. Like in this graph, we can see that's mostly like a lenticule shaped graph. So, the hysteresis that we talk about is basically the distance, the difference between these two, the gap between these two lines. That is between the stress and the strain, the hysteresis is measured. So, why does it matter? I'm sorry, there's some problem with the format. So, why does it matter? So, it helps us in diagnosing the corneal disease. It is safer and more effective for like to give to make sure that we are able to give safe and more effective surgical treatment to the patient, and it provides us customized, optimized care as to what kind of surgery or refractive surgery is useful, and also intraocular pressure measurements that can also get affected because of the cornea. So, what's in store for us as a refractive surgeon? It helps us to decide which procedure is going to be biomechanically stronger, and it also helps us in differentiated normal corneas post-refractive surgery, which are normal, compared to that of post-refractive ectasia. And also, it helps us in predicting the refractive ectasia at an earlier stage. As we know, according to studies, that before your morphological changes, the biomechanical changes appear earlier. So, it always precedes it. So, we can, if we can catch the ectasia at an early stage, we can then prevent further deterioration of vision. So, biomechanical assessment is like and ex vivo, it's like we can do it with strip extensometry, there are inflation tests, speckle interferometry, etc. While in vivo, we know that Aura, which has been there for a long time, and started since 2005. Then the recent one is Corvus ST, and also Berlin microscopy, which is still in the initial stages, so we don't have much information about it. So I'm going to cover mainly the Corvus ST part. So Aura was the first tool, as I described, and it was first introduced in 2005, and it takes into account the overlap between the first applanation, because when it's a puff of air and there's a collimator and there's a puff of air which is just directed towards the cornea, and it measures the applanation. After applanation, there's indentation of the cornea, and then once it comes back to the normal shape, there's a second applanation. So the difference between the first applanation pressure and the second applanation pressure is the measure of the hysteresis of the eye. So the factors that we need to know about Aura is the corneal hysteresis, that is the viscous dampening capacity of the cornea, and the corneal resistance factor, which is the overall corneal resistance. And along with that, then it also gives us IOP, cornea corrected, and IOP-G, that is Goldman applanation tonometry corrected. But the thing is that there are various studies that have been conducted over the years, and it has shown that Aura has mild to moderate sensitivity and specificity. So the correlation and accuracy is quite poor compared to that of Corvus. Also, we can say that corneal hysteresis can get affected by age, the corneal thickness, and keratoconus and glaucoma. Coming to the Corvus ST, so it's a non-contact tonometer. It uses the Shamflick principle to measure and calculate the various parameters that are involved. The most important two parameters is that is the corneal biomechanical index and the topographic biomechanical index. And moreover, it is a very rapid method of measurement, close to around 140 scans in 31 milliseconds only. And there are now we have more and more studies coming up on Corvus ST and its correlation to that of refractive surgery. So actually, I had a video earlier which is somehow not playing here. So here we can see in this photo, before measurement, this is the cornea is in normal shape, and then there is a first applanation. There's a puff of air that just applanates the cornea. That is the first applanation, and then the indentation of the cornea takes place. That is the highest concavity that the cornea achieves. After that, once the cornea tries to come back to its normal position, we can see the applanation again. That's the second applanation, and then the routine measurement. So there are various ratios like deformation amplitude and the HC arc length. These all parameters are then measured, and then we get a value. There we get various indices on the Corvus, which can then be correlated further. This is how the map looks like, and then we give the ratio, the arc length, the deformation amplitude, and everything. So what is CBI? That is the corneal biomechanical index, which was devised by Vinciguerra et al. So they have shown that there's a regression analysis that is used to look at the deformation response of the eye, and they came to the conclusion that the corneal biomechanical index of more than 0.5 is significant, and for frank keratoconus, 1 is CBI of 1 is considered to be problematic. So topographic biomechanical index is another important index of the Corvus. So it was described by Ambrosio et al. And they described, they compared it to the BAT map of the posterior elevation map of pentacam, and they've shown that this is superior to that of BAT map of pentacam in detecting patients of suspicious keratoconus and subclinical keratoconus. Moreover, they utilize a artificial intelligence approach. Now they have more of like Wixomix, like in association with Narayan et al. They have also utilized the artificial intelligence approach, but that's still in the laboratory phase. It's still not applicable in real life scenarios. So TBI is another index. So the more than 0.29 is sensitive for firm fresh keratoconus, and you can say the more than 0.79 is seen in frank ectasia. But since there are so many parameters, we need to know how do we interpret these values. So it has been shown in studies by Elise et al. That the two-dimensional univariate analysis, like the deformation amplitude, then the first applanation pressure, second applanation pressure, etc., they can be affected by the corneal thickness and the intraocular pressure. So it will not give us the actual value or the real value that we can stick onto. So they have advised us to stick to multivariate indices, which are independent of the thickness and the intraocular pressure, like stress strain index and the Ambrosio relational thickness, along with SPA1, that is the ratio of the stress, that is stiffness parameter, along with that of the first application pressure. So these are various ratios that should be utilized in order to get the better value and a better application in our patients. So interpretation of this corneal biomechanics, should only, like, as we know that it takes into account the central 8 millimeters of the cornea. The deformation of the central 8 millimeter of the cornea is taken into account with these machines. So the periphery of the cornea, especially the limbus and the sclera, that is also important, as we know that the stiffness or the flexibility of the sclera can also has effect on the central cornea and its biomechanical properties. So that should also be taken into consideration. So the finite element modeling system, which is based on the stress strain index, is not influenced by CCT. So they say that the actual strength of the cornea can be measured using the SSI. So this is one study published in the American Journal of Ophthalmology, where they had taken into account emmetropes along with myopes, and they divided the patients into mild, moderate, and high myopia, and they performed Corvis ST biomechanics on the patients. They found that the myopia, based on the different degrees of myopia, especially in the patients with high myopia, there was higher deformation amplitude. That shows that, yes, the more high the myopia is, the cornea becomes more less biomechanically strong. So that has a application in our patients with very high refractive error, where we usually do not advise corneal based procedures. We advise them maybe lens based procedures also. That also shows that with as the refractive error increases, spherical equivalent increases, our corneal biomechanics also goes down, irrespective of the keratoconus or anything. So again, I'm sorry about the slide being mixed up. So Berlin spectroscopy, just one line about it. This is a newer technique, again, minimally invasive technique. It takes into account the light scattering property of the eye, and it takes into account the entire corneal surface. But usually we don't have much studies based on the Berlin spectroscopy. So coming to the refractive screening part of our, I think I have just little time. So the Actasia risk score system should take into account the biomechanical strength, the topography, along with other parameters, that is the treatment related factors like thickness of the flap, the residual bed thickness, and the patient's age. So the question is, why do we need the biomechanics at the first place? We have pentacam, we have the OCT, and then we have our own measurements. What is the need for this? So this is an Indian study which was published in 2020, which showed that up to 0.34% of the patients of post-refractive surgery ectasia, in those patients, 30% of the patients did not have any identifiable risk factors. So they attribute the biomechanics to be the reason for this non-accountable risk factor. Apart from that, another study by Moshifer et al. Has shown that here, in like numerous surgeries performed for PRK, LASIK, as well as SMILE, there were a limited amount of patients where incidence of any risk factor was not identified. So they again attribute biomechanics to be the reason for the same. So this is just a cutoff value, which is just more theoretical. Again, for CBI more than 0.5 and TBI more than 0.29 is something which we need to remember to detect early keratoconus. Again, another debate here is like, which is still not completely answered, is which refractive surgery gives the best biomechanical, leaves the eye with the best biomechanical strength. So as we say that PRK and LASIK, only the anterior epithelium and the anterior lamella are getting ablated. They are known to have a better biomechanical strength compared to LASIK as well as SMILE. But there is still some debate going on, because initial studies had suggested that LASIK gives a good mechanical strength compared to SMILE. But the recent studies have again shown that SMILE, on the other hand, because it's a lenticule-based thing and the anterior cap is still left out, it gives better biomechanical strength. But studies are inconclusive overall. So again, they have come up with another index called CBI laser vision correction. So this is a multicentric study which have come up with this parameter of corneal biomechanical index laser vision correction, which is known to have a very good sensitivity to the tunes of more than 90% and specificity of more than 97%. They say the cutoff value of 0.2 of CBI LVC should be considered in patients of post refractive surgery ectasia. So to conclude, I would like to say that assessment of the corneal biomechanics may help us in understanding the patient and give more of an individual based approach for corneal procedures, and we must rely on multivariate analysis or values than the univariate values, and it can also help us in customizing the surgeries to each and every patient in a better way, and also to detect the post refractive surgery ectasia at an early stage. Thank you very much.
Thank you, Dr. Sonam. That was a very comprehensive talk, and it's I'm sure that the biomechanics is a very important, sometimes unknown factor when it comes to corneal ectasia, and we have studies have shown that post pregnancy, I mean during pregnancy and post childbirth also, it has an effect on corneal biomechanics. And Indian eyes, I don't know whether you have reviewed the data of Indian eyes versus because most of the data is from the Western population.
Yes, that study that I showed, they had 0.32% of the cases which had post-refractive surgery ectasia, out of which 30% the cause was not known, because not every patient had undergone a biomechanical study prior to the surgery. So they are attributing that the biomechanics could be the reason for the ectasia in that Indian study that was done.
Right. Thank you very much, and it gives me great pleasure to invite Dr. Samar Basak and for his talk on LipiView and LipiFlow, and I think uh, we look forward to hearing from him his experience. It is expensive, but is it really worth it in patients? Dr. Basak, please.
Thank you, Dr. Amit, and this is a great honor for me to be here, and this is maybe third or fourth IC we are doing over last few years. So I'll be talking on tear film diagnostic LipiView and LipiFlow. I do not have any financial interest to disclose. So I'll start with a case. This is an 8-year-old girl, use of digital devices for more than 8 hours, recurrent red eye and marginal keratitis in both eyes for 1 year. When asked about her digital screen time, her parents are very reluctant to admit that during COVID time, she used to spend 10 to 12 hours per day online classes and leisure activities on iPad. This habit still she is continuing. We treated her first medically, then we ordered LipiView. And this is the LipiView picture of 8 years old girl. So we are shocked to see this kind of meibomian gland. Virtually there is only few gland left. So dry eye and MGD is a global problem. Recently it is more. If you see that the prevalence is between 8.7 to 30%, MGD is in 38 to 68%, more in Asian than Caucasian. So we had studied long time back, about 12 years back, and in our study we showed that MGD is 37%. There are other studies from North India, they have also shown that MGD percentage is quite high, almost 31%. So MGD in cataract population, we know that this is a problem. 52% of patients had MGD and 56 had meibomian gland atrophy. But on the contrary, 50% of the patient of MGD were asymptomatic. This study was in JCRS. And there is a correlation between cataract surgery and dry eye and MGD. So error in biometry, post-op discomfort, worsening of symptoms and anatomical disturbances. So they go in a vicious cycle. So there are many literature along in the, and all are recent literature like 2018 onwards. You see that there are studies, they have shown that alternation of the meibomian gland expressivity and direct role play in cataract surgery by obstructive mechanism. Tear film LLT significantly goes down. LLT means lipid layer thickness, both uh, during and this is after cataract surgery. So there are also meta-analysis available. So if the patient is having pre-existing MGD, so it gets worsening. This is interesting study in clinical ophthalmology that despite more knowledge and more accessible to treatment, MGD is highly prevalent among ophthalmic healthcare worker, among ophthalmologists and other healthcare provider. The prevalence is 61%. So targeted based therapy on dynamic mammalian gland imaging is effective in improving both objective and subjective measures of MGD. So there is also role with laser refractive surgery, MGD and dry eye. This is a busy chart, and there are actually algorithm is there. Then you have ASCRS preoperative OSD algorithm is there. The thing, as they always say, that the acronym is LLPP, look, lift, pull and push. So you look for the gland opening, lift the lid, pull and evert and also push. So if you have certain gland secretion, then you should be aware that you should not proceed for direct cataract surgery. You treat them, then proceed. So these are the slit lamp. We all know this, that low tear meniscus height, reduced tear length, mucus strand debris, slow or no movement of the debris. Then mammalian gland expression. There are different kind of mammalian gland expression. This for the secretion, then toothpaste sign, and sometimes you see interface fringes of MGD's LLT layer. So LipiView is a system where it implies infrared ray to capture the picture. Then it was also initially called LipiScan. The current version is LipiView 2, and LipiFlow is the treatment part. So LipiView 2, the components are two basic component. One is functional component, the another is structural component. So as I said, interferometry and lipid layer thickness it measure. Blink dynamics it can measure, and infrared mammography with transillumination device, a structural component. So if you see, this is like a oil in water kind of thing. So if we see that, we can always look for this. So normal lipid layer thickness is more than 60 nano. So if you see this machine shows this kind of picture. With a normal blink, you see this, there is beautiful color interference pattern, and it moves in a light in a different speed. But in LLT, low LLT, the speed is actually very slow, and the color is like different color. So you can capture these images and show to the patient. This is also how they do the LLT. So LLT, if it's less than 60, then we need to think about lipid layer thickness. It also gives the area of partial blink rate. So I'll show a typical example, and this is the mammography direct, then transillumination, then dual mode for better contrast, and transillumination is available for lower lid only. So if you see this, these are from this gland dropout and dilatation of the drug. So there is a obstruction of the mammalian gland orifices, then there is dilatation, then it may be classified as mild, moderate and severe. Then dropout, you can see that in severe cases there is much dropout, there is no mammalian gland is the lowermost picture. So, but it doesn't, Lipi view doesn't quantify the how much percentage. The other devices, they also quantify it, like how many percentage of mammalian gland drop out, like 37%, like 25%, this kind of data they also gives. This is my mammalian gland. It was done in 2018. We had this December. So you see that LLT is just in borderline. I am a totally partial blinker, no complete being 100% partial blinker. C factor means if it is more than 0.9, it means your capture is right. So if you see my gland, the glands are upper lid, if you see both the eyes, it is disturbed. There is no gland pattern. It is tortuous. In some places that it dropped out area, so much dropped out. The lower lid is also similar kind of picture. So apparently we see that we are right, but these are the, we have checked with our many, we didn't come with any data or any publication. We have checked the several. So I had to underwent Lipi flow. I did thrice during last 7 years. So we always think that it should run for 2 years or so. Sometimes we see this kind of gross dropout area, and if you see that the LLT is 52 or 59, capturing is good, partial blink, of course 13 out of 14 blinks. During that eye test, it is 90%, more than 90% partial blinker. So this is another case. You see, though there are dropout area LLT shows, these are false high LLT, because sometimes patient squeezes during the that time some amount of lipid secretion, whatever gland it comes at, it gives erroneous. But look at the anatomy of the mammalian gland, nothing is there. Then this is another example. It matches like 25 average LLT. C factor, capture factor is 100% correct, and both dropout area and so many blocked gland. Is also extensive dropout area. There is no gland in the lower lid. You see, there is no gland. Still the LLT is little higher. So it is again that squeezing, and small little glands are there, few remnants. They actually gave those lipid layer. And this patient asked for multifocal IOL actually. So any case of multifocal IOL in our, or premium IOL, EDOF, anything, we always go for mammalian gland dysfunction, Lipi view. And then we ask, and if it is fine, if it is grossly disturbed like this, there is no question, and whole, because patient overall the tear film stability is not there. It's severe kind of evaporative dry eye. So he or she will never be satisfied with a multifocal IOL. So in pediatric group, is it increasing? So this is my area of interest recently after this COVID. And you know, there are many reports, smartphone and digital devices, they have done many case control study. During the COVID time, we know that online classes and everything. So if you see that power of blink, and we blink less on digital platform. Normally we blink 15 to 20 times, average is 18. You go with the respiratory rate, it is the same as respiratory rate. The cycle, so when we blink less and it is not a complete blink, that means upper lid is not touching the lower lid. And these are vertical gland. Unless it touches the lower lid, there will not be expression of the mammalian gland secretion. So there will be stasis of mammalian gland secretion within the tubular racemose gland. And eventually, this is a kind of disease atrophy. Gradually it becomes dilates, and gradually segment loss and atrophy. This is the thing which is going on with the current situation over last decade. So we see other child, you see this is the 11-year-old child and you see the mammalian gland, it is horrible. So when this child in our age, what will be his or her mammalian gland like this? We always really worried about this. Then this is another gross dropout, against false high because during the squeezes too much. This is another example, 25, 30, you see the LLT and partial blink. So we have to treat them. There are many methods are available. I have tried in our hospital with demo and we kept them for 1 month, 2 months like that. Some methods are good, some methods are bad, but mechanical gland expression in today's era is difficult. Gland probing is difficult. So LipiFlow is one of the system, alternative Miboflow, system, ILUX, and then IPL is there. So IPL is, it acts at a different mechanism. But what I feel that LipiFlow is going good over last 6 years in our hospital. And it is actually, you can actually realize that it helps because it applies temperature between 41 to 43 degrees Celsius, both from the inside and from outside. So it is like, and it is a 12-minute cycle and it gives pressure, maximum 6 psi, and a 12-minute treatment cycle is very much effective. Total time is around 20 minutes to, these are all digital device, so you have to, it is software designed like this. They have come with a different modules now, this activator. So heat from, so there are 3 components, thermal pulse therapy, heat from inner aspect and massaging of the lid. So this is the whole unit. So it also protects the cornea from, there is a vaulted cornea shield is there, the lid warmer is there, and silicone inflation massager. So it acts like this. This is this animation from them. You see it acts like really, we call it eye spa, eyelid spa, because you feel that when you do it, that give me more. I mean, treat me more, this kind of sensation. It is so much, I mean, soothing and no, like in IPL you have to apply so much cream and etc. Sometimes it is difficult to do that, and sometimes it's also burned near the discoloration of the skin we have seen, so we abandon that thing. So there are many studies are there, it really helps. You can go through all the literature. I have read all this literature. It is actually working. So there are different, so before cataract surgery you can, then you do the surgery even after cataract, even for that, for also refractive surgery also. And of course these kids, we are treating these kids, sometimes the applicator size is so much. There are pediatric version is available, but it is not always available in India. So we order, it comes once in a while. That time we treat this with child. And there are like randomized control trial, there are meta-analysis, everything is there. So if you see that this particular article in December 2020, they have suddenly claimed that visible mammalian gland structure increases after vector thermal pulse treatment, that means LipiFlow, in dry eye disease with in MGD. They have shown, if you see that, they have shown the picture on both sides, that they have given several examples and they have shown that with image software, this glands are pre and post, it is increasing. So I said it is good. So we looked from then our patient. So we do give the treatment and see after 1 year, and you see this is my patient, pre and post. This is captured on 21 September, it's 23 April. If you see the lower lid and upper lid, both the structure has increased. So this is, then on, I make it a habit, the patient when comes for follow-up, 1 year, at 1 year or 1.5 years, you see the glands are actually increased, and the shape of the tubular racemose type of appearance is actually, this is pre-treatment, this is post-treatment. After a gap of say 1.5 years, you see this lower lid, all glands, this is same patient. So I have now, we are on the writing mode of a manuscript. I have now captured almost 29 such patients over last maybe 1.5 years. And this kind of picture we are getting, and actually these patients are doing fantastic. Now we also, this is not only, we have to tell them that reduce the work on digital platform. We also tell them that see the concept of Johnson baby soap and that stick Johnson and Molly's, and then you clean. Those are, you yourself cannot do it. It is not possible. So my saying is, during taking bath, most of us sometimes take hot water, or colder days you can shower on a bath. Create foam around your eye and you just massage. There is no plan like vertical, horizontal. You make it a circular movement like this, so it covers all the thing. And if you do it twice in a day during colder, when you go home, we actually wash our face. That time you do during bath, shower. So hazards of boiling water or sodium bicarbonate, Johnson baby soap, earbud, all this, you cannot do it. So that is, this goes along with it. Along with that, you have to give lipid, teardrops, which contains lipid. That is, only one thing is available, probably Indian company will come up. So indication is there, so you have to choose we have seen in allergic VKC, you can see lot of dry eye disease, patient with glaucoma with meibomian gland. Then if you see that, you always tell that the goal is like this, but you have to carry the other things, and you do not expect immediate results, so you may have to wait 2 to 3 weeks to get the work, and you take the call after 1 year, see again. So basically it is required for both this cataract refractive surgery pre and post, and also for population IT, those IT workers, the children who are on online platform. And pre-procedure and post-procedure, you have to follow up this patient. And it is good if your selection is good, like I showed some of the picture with severe meibomian, no meibomian gland, then it will not act, because there should be some amount of meibomian gland. So it is actually working in most of our cases. You exclude those cases. Thank you very much.
Well, thank you, Dr. Basak. It's always such a pleasure listening to you talk on MGD and LipiFlow. And I think, considering the burden of dry eye and the expense of dry eye in patients, maybe it's not a bad idea if it becomes more affordable for people, just like they go for so many of their treatments and stuff like that, to just get this mechanical expression done at maybe every 10 years, 15 years. It has been shown that if you get one session at an earlier age, the incidence of dry eye in older age may go down significantly. We know it is there. We can't express it. There's no way you can, like you were saying, sir, ki massage, injection. People cannot do it, and cannot do it efficiently. The heat you put with your hanky or a cotton or something does not penetrate enough to melt the meibomian secretion. So I think maybe it should be an everyday booth or something where you can get some expression done and it helps your.
In our practice, we kept the price very much lower. It is actually supportive to the patient. Cataract is our business. So if you talk about the charges, you know that our charges for Lippy View is only 900. People takes 3,000, I know. And the treatment for Lippy flow is 15,000. So
That
I
is
took
amazing.
Bangalorean IT people
Yes.
that you fly to our hospital,
Yes.
you go for Lippy flow, fly back, still you will gaining more.
Yes.
So it is not for making money.
Correct.
It is making your other patients comfortable.
Right.
There you will do your business. This is our motto. That's why our Lippy View, Lippy Flow is going good. Every day we do a lot. Line deke karate hai logon.
Because this machine itself is costing
It
60,
is
70
costly.
lakhs.
It is
So
costly.
you have to take care of the machine cost plus the activator itself is costing 6,000-7,000 rupees. So that resultant cost is, I think it's a very incredible price in a private center to give.
That's why.
I mean, we do it for 7,500 rupees, but we don't have to pay for the machine. The government buys it for us.
But we have calculated that if the patients are on a queue, your machine
Fantastic.
cost comes up.
Right, well, I would like to thank the audience and thank all the speakers for such a wonderful session. I would like to invite all the speakers on stage for a photograph. Also, Dr. Lekha and Dr. Arpita, you've been a part of the preparations we have done. Please come on stage for the photograph as we finish the session. Thank you so much. And we look forward to having the same course next year as we've been doing for many years now. Thank you. Thank you.